Hello, hi everybody. This is Felice again, and I would like to present today a lecture for trainees and clinicians on neuroradiological assessment of craniofacial syndromes. And this is a lecture that I did for the skeletal dysplasia group in UK. Now, this is the summary, and I think the most important thing when approaching craniofacial abnormalities is to understand the normal cranial development, and also, not only as a radiologist, but also as clinician, to understand which kind of imaging technique is optimal for which indication. Preoperative planning, craniosynostosis, um, uh, complication, associated brain findings, and so on. So basically, when to use CT, when to use MRI, etc. I will discuss mainly pattern of craniosynostosis, but also some association between fronto-nasal dysplasia and brain abnormalities. We'll speak about goldener and finally about achondroplasia, in particularly what's new in achondroplasia. Now, uh, let's start with normal cranial development. So this is the 3D reformat. These are the 3D reformat of a CT scan in a neonate, and you can see that everything is open. The anterior and posterior fontanelles are open. The metopic suture is here, coronal suture, sagittal suture, C and D lambdoid suture. There are also other minor, let's say, suture, sphenoidal fontanelle, squamous suture, mastoid fontanelle, and sphenosquamosal suture as well. Now, one thing that is very fascinating to me is the development of the skull base and in particular of the occipital bones. Why? Because there are a lot of possible pitfalls in the interpretation of the developing occipital bone that is formed by four bones. We have anteriorly this basioccipital bone, two exoccipital bones surrounding laterally the foramen magnum, and then the squama occipitalis, which is divided in the supraoccipital bone that is derived from cartilage, and the intraparietal bone that is more cranially and is derived from membrane. It is a membranous bone. It's important because in between these two parts, there is this mendosal suture that should disappear but can simulate a fracture, for instance. And that's from a beautiful book from Shapiro and Robinson. It's called The Embryogenesis of the Human Occipital Bone. It's from the 70s, but it's amazing and also shows the anterior basion and posterior opisthon points of the foramen magnum and the mendosal suture identified by these arrows. So you need to know the normal to recognize the abnormal, and also you need to know how to approach these as far as the genetics is concerned. We have multiple genes, sometimes suture specific, sometimes there are syndromic craniosynostosis, but it's very important that without going into details, but because there are new genes every month discovered, murine models, and so on. But it's important that, especially if you are in a syndromic context, always to have a multidisciplinary approach and involve your craniofacial specialist and your geneticist. Another thing that is fascinating is the phenotypic genetic variability and overlap. So if you have one gene abnormal, you can have several syndrome, Cruson, Upper, Pfeiffer, and so on. Um, and sometimes the same gene gives you same syndrome, a specific syndrome, like in this case, which can have different phenotypical appearances as far as the craniosynostosis are concerned. Also, if you have a syndromic craniosynostosis, And we don't see much in the Western world anymore this, but we can have an evolution in a total craniosynostosis with this cloverleaf skull deformity, which is very dangerous to the child. What are the imaging techniques? First thing you need to remember, guys, is that if you have a good clinician, they will be almost always right when it comes to the skull shape. So they will ask you for imaging to confirm craniosynostosis that they will have already identified in the clinical examination. And to do so, we never use a radiograph. This is suboptimal. We use CT, which we can do with a low dose, very low dose CT, will not give us a very good view of the brain parenchyma, just enough to exclude acute complication, hydrocephalus, hemorrhages, and so on, but will give you a perfect view of the bones without radiation burden, very significant radiation burden to the child. Most important thing, we need the 3D reformats. Once you do the 3D reformats, diagnosis of craniosynostosis become very, very easy. We may need MRI for brain abnormalities and association. We show you some example, but also sometimes CTV or MRV because the craniosynostosis, especially syndromic craniosynostosis involving the skull base, can have a problem. It can create problem in venous drainage, which in turns can create issues in preoperative planning. So sometimes we will need CT venography or MR venography. 3D CT, why we use the CT? To differentiate with mimics, sometimes it's difficult to diagnose a position, to differentiate position plagiocephaly from a synostosis, fractures, unsuspected additional synostosis or involvement of the skull base, preoperative planning, and postoperative assessment. Very, very important. But remember, this is very low dose, and this new techniques allows us to reduce the average dose of 85%. So really, the difference with radiograph is minimal to none in terms of radiation burden, but the change in the diagnostic yield is dramatic. Now, I would like to suggest you this paper from Helen Branson, and Manu Schroff from Toronto, done in 2011. And they show a lot of technical parameters in approaching 3D CT. And they also basically, give to your tech, your radiographer, this image, where they will know how many projection to create for each CT. So you always have the same projection and you can compare the scan. So it's a very useful practical paper. Now, how to report a 3D head? What we focus on, we focus on gross ventriculomegaly, hemorrhages, calcification. Sometimes we have this appearance that you can see here on the right, also on the left, actually, on this copper-bitten skull appearance, which sometimes can be misinterpreted as a sign of raised intracranial pressure. Basically, what's happening in these cases is that this copper-bitten skull is due to the impression of the gyri on the surface of this small skull, because the brain gyri are growing while the skull is stuck because of the craniosynostosis, and can be associated with raised intracranial pressure. But please remember, raised intracranial pressure is a clinical diagnosis, and radiologically we can just support it, but we should be very careful to overcall these abnormalities. We document the head shape, we look for the orbit, the facial bone asymmetry, and we look at each suture showing if they are, or describing rather, if they are absent, if there is a ridging, sclerosis, partial fusion. But do not forget to look at the skull base and craniovertebral junction. Head shape, we have trigonocephaly, which will be diagnostic of metopic synostosis, scaphocephaly, sagittal synostosis, and then anterior or posterior plagiocephaly, or a brachycephaly in case of bicononal synostosis. So it's the short skull. Let's see some image pattern of craniosynostosis. This is a child who came for suspicion of lambdoid synostosis, but if you look at the 3D and also at the CT here, again, radiograph very, very difficult, but if you look at the 3D, the two lambdoid are visualized, so there is no lambdoid synostosis. The important thing is that if you look at the internal auditory meatai, the one will be pushed anteriorly, and the child will also have frontal bossing without the mastoid abnormal bump that is typical of lambdoid synostosis. So this is a position of plagiocephaly. And positional plagiocephaly is the most common cause of abnormal skull shape in an infant. And when we know that the child needs to be positioned during sleep to avoid that. But because this is not a fusion, all the side of the skull is pushed anteriorly. And this is what we will see in the positional plagiocephaly. So normal appearance of the suture, frontal bossing, and internal auditory meatai pushed anteriorly. This is how the lambdoid synostosis look like with the frontal bossing, sorry, with the mastoid bump, without frontal bossing. And look, simply the lambdoid is fusion on 3D reformat. So 3D reformat are very easy to read and are critical in the diagnosis of craniosynostosis. And of course, you will not have the anterior displacement of the inner ear and internal auditory meatai as we have in positional plagiocephaly. Lambdoid synostosis is rare, is extremely rare bilaterally in non-syndromic causes, but is very common in syndromic synostosis like Apert and Pfeiffer syndrome. Uh, the most common isolated synostosis is the sagittal synostosis with this elongated skull shape. There are some familiar cases, and for some reasons, it's more common in males, probably because males have more androgen that push towards sutural osteogenesis. And this is, again, the clinicians are very good in diagnosis this clinically, and there is a strong clinical radiological correlation. And this is the elongated skull head shape. Why? Because if you have a fusion of a suture, the skull will grow along the axis of the fused suture. So in this case, because the sagittal suture is fused, so we are dealing with the sagittal synostosis, the skull will not um, grow laterally. What about the metopic synostosis that is anterior to the coronal synostosis? So here we see the sagittal synostosis is fused, the two coronal synostoses are fine, but the metopic synostosis is also not visualized. In case of metopic synostosis, look at the age of the child. Why? Because actually, the metopic synostosis fuses very, very early, between 3 months and 2 years. Actually, most of the metopic synostosis fuses by 9 months, while look at the other, the suture, sorry, metopic suture, not synostosis, but the metopic sutures is the only one that fuses so early. Lambdoid, sagittal, coronal, squamosal, they are fused in the adulthood. And if you have a doubt, you can also measure the synostosis on the suture to diagnose synostosis on the axial thin bone reformat. But what I want to stress is that this is a beautiful paper, but we never use this because the 3D is so accurate. But what is important is that they show how fast in the first year, particularly in the first months, for instance, sagittal and coronal narrows. And you know from this measurement that the lateral coronal, for instance, is fused much faster than the medial coronal. And 1 week ago, I received a case of a fused lateral coronal from abroad. The surgeon asked me what I thought, and I showed this paper. describing this. So remember, this is a pitfall. Lateral aspect of the coronal suture fuses before the medial aspect. Don't be fooled. Don't call partial craniosynostosis, especially bilateral symmetrical cases without abnormal head shape. And this child I'm speaking about was 13 months, so after 1 year, when the suture are very narrowed and the 3D reformat was actually misleading. Metopic synostosis, before we thought was rare, but sometimes we know now it is much more frequent. Important point, remember the trigonocephaly that allow us to diagnose a possible metopic synostosis beyond the 2 years of where all the metopic are fused. Remember that sometimes they can be diagnosed in utero. They are very early on, and I can show you some example in a while. And a lot are syndromic, genetic, and associated with brain malformation. So if you are dealing with trigonocephaly, please ask for an MRI of the brain. This is the typical appearance. Look at the anterior skull. It's very small, it's very narrow with the ridge. We have hypotelorism and also this upper deviation of the medial orbital rim called quizzical orbit. Remember that I showed you before, the copper beater skull is not per se a sign of raised intracranial pressure if you don't have the clinical context. The presence of bony ridge is not per se the sign of a craniosynostosis, so it can be normal. So if you are dealing with, if you see a bit of bony ridge in a metopic without trigonocephaly after 2 years old, don't call it metopic synostosis. This is another interesting case. Just show you that at 9 months of age, 100% of this metopic were close in normal children, but in general, before the evidence of metopic suture fusion before, even before 2 years, should not be called metopic synostosis without trigonocephaly. So the diagnosis is clinical, and be aware of this discrepancy between the age of fusion of metopic synostosis versus the age of fusion of the other sutures that are much that happens much later on. And this is what I was talking about: fetal MRI on the left, ultrasound on the right. This is prenatal trigonocephaly due to a metopic synostosis that can have a genetic cause or a toxic cause in case of valproate toxicity. What about the coronal synostosis? Well, it's more common in female, gives you brachycephaly. It gives you this typical harlequin deformity, and there are some genes implicated. And again, like the lambdoid, bilateral coronal synostosis can be seen in syndromic association. Look at this. This is the typical harlequin deformity of the orbit, unilateral coronal synostosis. Remember to look at the skull base tilting and the mastoid bump in when there is associated lambdoid synostosis. Look at this. You cannot see the coronal here. You cannot see the lambdoid here. You have the mastoid bump. You have association of two sutures synostosis. And I would like to suggest this beautiful paper by Susan Blazer in Pediatric Radiology 2015 on this topic. Non-synovial bilateral coronal synostosis, you can see the harlequin deformity is less accentuated, but again, diagnosis is easy. This 6 months old, the metopic is still open, but diagnosis is easy on the 3D reformat. Syndromic craniosynostosis. We have bicoronal synostosis in most of the cases, FGFR mutation. We can have associated extremity malformation, Abercruson, Pfeffer, different mutation, but it's important that in these cases we scan also the brain and we check the skull base and the veins at the skull base for the possibility of hypertrophic vein, collaterals, and so on. This is an upper syndrome, also showing the extremity malformation with bicoronal fusion, very well seen. here. And you can see also in these cases, the anterior fontanelle and the upper part of the metopic is enlarged. This is a Cruzon syndrome. Later on, 7 year, all the sutures are fused. And from Wikipedia, the typical fascias of this Cruzon patient. Cloverleaf deformity, I show you already, we don't see often this evolution, but this is the expected evolution of untreated craniosynostosis. There are other patterns described. This Z pattern when one coronal, the sagittal, and the other lambdoid are involved. Mercedes-Benz pattern. Sometimes they try to associate with genes. But again, just look at the 3D, just described, keep it simple, is what I suggest. Postoperative is important. Again, the cranial vault remodeling, reshaping, like in this case, the CT 3D reformats give you and give to the surgeon a view that is very similar to the surgical bed. Some people use the spring mediated cranial reshaping, where the force that the spring applies to the suture to keep it open needs to be tailored to the specific patient. So it's a bit more complicated, but also less invasive. Now, speaking of association between malformation in the bones, in the skull and the face and the brain, I want to show you two cases of fronto-nasal dysplasia. This is a 5 weeks old with cleft and lip palate. You can see also the abnormality in the nasal bone here and the missing bone here. This is the 3D. This is the 3D volume rendering of the face. This was a diagnosis of frontonasal dysplasia. And they asked for the brain as well, because there may be some brain abnormalities. And in this case, we see bilaterally a lot of nodule of gray matter heterotopia, but also an area of transmantle heterotopia and polymicrogyria on the left-hand side. Now, there is another lecture on gray matter heterotopia. It's another fascinating topic, but if you study gray matter heterotopia, you will know that some of them are genetic and there are some pattern recognitions that we can use, so different association. Some are due to an insult or either a vascular insult or whatever create embryogenic abnormalities. And frontonasal dysplasia seems to be one of these cases. And in fact, we have a couple of papers where we have nodular heterotopia in association with frontonasal malformation. There may be an association with the male, so maybe X-linked, but to the best of my knowledge, no genes were found. So that's very important. Why? Because identifying brain abnormalities, like in this case, associated with abnormalities in the face, impact the management of the child. These children will have increased risk of seizure. We know that they have developmental delay. And also, there is genetic research that we can do. This is another case from nasal dysplasia for preoperative planning. This child has also a huge lipoma sitting on the corpus callosum. The corpus callosum is abnormal, and this is the MRI with the typical hyperintensity of the lipids that we see. So there are, again, if you read the literature, association between frontonasal dysplasia and the lipoma of the corpus callosum, no neurological abnormalities were found in some of the patients. Some others show that corpus callosum lipoma can be not only in the anterior part, but also posteriorly. But these are very old papers, so it's a very well-known association. Again, probably due to something embryologically going wrong and allowing some fat to sit on the corpus callosum, as well as some abnormalities in the bone of the face. Just one word about oculoauricular vertebral spectrum, or golden R. There are abnormalities in the vertebral bodies, in the face, hemifacial microsomia, inner ear abnormality, and so on. But it's very important that this spectrum of abnormalities, like Bactrel or other association, are probably non-genetic and due to something, again, that went very wrong in the early development. Interestingly, we started to see this patient because we are studying inner malformation, and we saw a lot of cranial nerves abnormalities in these patients. Look at the fifth nerve here in these two cases. This is a trigeminal nerve going into this enlarged Meckel cave, and from the Meckel cave, the seven nerves goes laterally, and there is no eighth nerve. So this malformation, sort of fused, and some are absent cranial nerves, may be associated with this syndromic, but interestingly are associated with maternal diabetes. And this observation I did years ago. We published in some review, and now another group, I think, is about to publish on AGNR. So it seems to be very strong. So remember that this can be a factor, and there are Murine models that explain this association between maternal diabetes and abnormal cranial nerves. This appearance of the cranial nerve was reported in some papers, as in other papers about Goldenar was also reported. So it's known more or less, but the association with maternal diabetes is quite new, and again will be associated with craniofacial abnormalities as per the syndromic association. Two words about what is new in the world of achondroplasia. It was recently published a paper, actually a couple of papers on achondroplasia foramen magnum score, basically saying that if you see narrowing with impression here on the cord and abnormal signal on the cord, we are dealing with a higher score, 3 or 4, and this may trigger, together with clinical abnormalities, like for instance in the sleep study, it may trigger the operation. So we need to use MRI to check the status of the spinal cord, not only at the level of craniovertebral junction, but also in the lumbosacral level. But when we use the CT in achondroplasia, we know that achondroplasia rarely develop hydrocephalus, but often have this problem in craniovertebral junction and lumbosacral spine. So we realized that despite the management guidelines for achondroplasia patients were published recently, there are no guidelines in the radiological assessment of achondroplasia. So we did this consensus statement that was endorsed by the European Society of Pediatric Radiology and the European Society of Neuroradiology. And we basically describe when to use what imaging modality. So I invite you to read this beautiful paper written by Jenny Wright. But most importantly, remember, MRI is the main way to assess these children as far as the CNS, the central nervous system, is concerned. But when we need to operate, when we need the CT to show the 3D anatomy and then the post-operative findings, like in this case, this is the pre-op, and this is the post-op after the foramen magnum decompression. Another thing is that we don't clearly know why, in comparison to FGFR3 craniosynostosis syndrome, that they develop hydrocephalus, raised intracranial pressure, achondroplasia, which also has a mutation in these genes, develop just narrowing of the canal with this large, of the foramen magnum with this large head, but no hydrocephalus. So please do not shunt achondroplasia. It's very rare to have obstructive hydrocephalus, and different phenotype. So we studied basically the changes in the foramen magnum in these children, and when compared to the Moenke and the Cruzen, for instance, the achondroplasia has all more narrowed foramen magnum and a different shape. This is a normal with this ossification, Kernicke ossicle is called. This is Moenke and this is Cruzon. The foramen magnum is not much impacted, but achondroplasia can have a more or less a decent shape of the foramen magnum, but can have hypertrophic nuclei of ossification in the posterior aspect of the foramen magnum that are and these are those nuclei create the stenosis and create the damage of the spine that will trigger in turns operation. This is probably due to Kerr-Ring ossicles hypertrophy. This is a developmental bony ossicles that then disappear over time. But we hypothesize that looking at all the CTs in this patient, so we are trying to unravel the pathogenesis of foramen magnum stenosis. We don't know why there is a phenotypic variability because this is 1 point mutation, and more studies are necessary for that. But please have a look to this paper because I think it's very, very interesting. Thank you very much for your attention. I hope this will be helpful. Please, as usual, let me have some feedback.